First of all, I want to apologize for the absence of our chairman, Professor Ken Julian, who is the one who had initiated, in fact, the health service initiative of Trinidad and Tobago, with UTT playing a very critical role. So again, apologies on his behalf, and he wants to wish this symposium every success. Again, members of the Board of Governors, I see a couple of them here. We have our Deputy Chairman, right, Professor Imbia, and a board member, right, another board member who again, I'm seeing at least two members here. Members of visiting team from Johns Hopkins, a very special welcome, right, to Trinidad and Tobago and to UTT. We look forward to your presentations, and I hope that you will find some time, right, to enjoy the rich culture of Trinidad and Tobago. Also, our co-partners in this initiative, Dr. Stacy Shamley, who is president of the Trinidad and Tobago Medical Association. We want to thank your association for partnering with us in this important initiative. All medical practitioners, members of the corporate staff, and academic staff of UTT, and a very special welcome to our students from the Masters in Health Administration, members of the media, colleagues. The University of Trinidad and Tobago is pleased to be collaborating with Johns Hopkins Medicine International and the TTMA with support from the Ministry of Health in organizing this one-day symposium, Innovations and Recent Developments in Digestive Diseases. I consider this to be highly relevant and very timely for a couple of reasons, and that's all I'm going to, I've been instructed I should not go beyond 5 minutes, right? It's very timely and relevant. First of all, the worldwide demand on governments from the population across the globe for a modern, efficient, and affordable healthcare system. So that's one reason why this is rising cost of healthcare across the globe. And that's a cause for concern of governments, and we in Trinidad and Tobago are not immune to that. And very important here, because of the rapid advances in science and technology that is taking place, basically we are outdated as we go through today's symposium. And a generation, as I keep saying, now is 2 to 3 years. That's a technological generation, and we need, therefore, to retool ourselves on a very regular basis. And this seminar, I think, is in keeping with it. Another point I want to raise here is that UTT, as a national university, is a firm advocate of the triple helix approach to development, to sustainable development. And what we are seeing here today is an example of that. We have here the private sector, so to be represented by the Medical Association. We have support from the Ministry of Health. We have the tertiary level institutions. And colleagues, we can only have a strong Trinidad and Tobago when all the various sectors come together, and we have to include the community-based organizations. So instead of saying the triple helix approach, I prefer to say the four-legged approach to national development. That is the public sector, the private sector, the education institutions, and the community-based organizations. And as I said previously, that diversity plus inclusion is equal to innovation. And that's the only way we can move forward, and that's what we are seeing here. And there are three critical roles that UTT as a national university must play. And if we look at this, one is that we are supposed to produce the human resource, the appropriate human resource, not only in terms of numbers, but also in the appropriate skill sets that are required by our present and future stakeholders. That's the role of us. Secondly, through our research, development, and innovation, and activities such as these, to find solutions to problems. And the third one, which I like to really stress, which you hardly hear about, as an education institution, we are supposed to keep our society one step ahead of our competitors. We're in a ruthlessly competitive world, and that's the role of the university. And what is happening today, brothers and sisters, this morning, is evidence of these roles as a national university. I just, on Friday, when we were on CNC3, to promote this activity, in an informal chat, why digestive disorders? Would be the layman interested in this? All they know about is cancer and cardiac challenges, etc., etc. This is something strange to the layman. And I just came upon some revealing statistics from the US. For every 100, I quote here, for every 100 US residents, there were 35 ambulatory care visits at which a digestive disease diagnosis was noted. And visits were common for all age groups, with the highest rate among persons aged 65 and older. But the second point is important. From the statistics, there were 2 million years of potential life lost. 2 million years of potential life loss, representing 8.5 years per death with digestive diseases as the underlying cause. And I think this needs to be brought out to the general public. And I throw out a challenge here to all medics here, and also those in the Masters of Health Administration program at UTT, to do the corresponding type of research here in Trinidad and Tobago and see what comes out of it. How many man-years are we losing, productive man-years, because of these things? The last point I'd like to mention now is that, and make reference to the Trinidad and Tobago Health Services Initiative. You know, this was inaugurated in 2007 by the late Prime Minister, Sir Patrick Manning. And this was a collaborative association involving the Ministry of Health, the then Ministry of Tertiary Education and Skills Training, Trinidad and Tobago Medical Association, and other UTT, with UTT serving as a secretariat. And emerging from that collaborative agreement, and I have a copy of this, and it's very revealing, in that in 2007, and this was approved by Cabinet, and they outlined 3 categories of initiatives: specialty and clinical programs, academic and research programs, infrastructure and management development. Those are the things which they identified in that project. And on top of the list was digestive disorders under clinical programs. However, because of, you know, I guess further discussions on financial limitations, the cardiovascular services and the diabetes service initiatives took preference. So here we are with our third initiative, so to speak. And we hope that this will, in fact, bear fruit in further discussions. And under academic programs, the Masters in Health Administration. Colleagues, I want to let you know that at UTT we have the Masters in Health Administration. This is the 10th year of the program. We've had 6 cohorts, and a large number of medical doctors are in fact attending this program. An improvement to the administration of our health facilities is very, very crucial to an efficient healthcare system. And what was interesting is the third category, infrastructure and management programs. Under it had facilities development, a new Port of Spain General Hospital, and a new Central Hospital. This was way back in 2007. I think the one which has come to reality to a certain extent is the Central Hospital, right? So we are still awaiting the replacement of the Port of Spain General Hospital. So all of these things were agreed upon in this health service initiative way back in 2007. And colleagues, again, I think my 5 minutes is more or less up. I see people are looking at me, right? There are a few things I wanted to talk about an efficient healthcare service, but I think I will leave that if there are question times later on, right? So again, I want to welcome all of you, and we really look forward to a very stimulating set of discussions, very active participation. However, all of this whole exercise could come to naught if the crucial conversation does not continue after. Thank you very much.
Thank you, Professor Narayan Singh. Next, I'd like to invite Dr. Stacy Chamley, who is president of the Trinidad and Tobago Medical Association, to say a few words.
Good morning, everybody, and thank you for coming out at this wonderful, ungodly hour. all of you who had doubles this morning. Welcome to Trinidad, and thank you for joining us. I am very impressed that your GI tract handled doubles at 6:30, 7 o'clock this morning. The Trinidad and Tobago Medical Association, I'm sorry, I had to say that. I was very impressed when Christina told me that. Professor Narayan Singh, the president of the University of Trinidad and Tobago, board members of UTT, Dr. Maria Bartholomew, respected consultant and previous consultant of the Northwest Regional Health Authority and now current board member of the North Central Regional Health Authority, Professor Kalu, professor and director of the GI Hepatology division of the Johns Hopkins, and all the Johns Hopkins professors and associate professors and recipients of awards in fall. Colleagues and members of the audience, thank you for coming out this morning. I'm cognizant of the fact that right now we should be hearing from Dr. Lowe about colorectal cancer, an initiative that the Medical Association highlighted 2 years ago in terms of screening, and primary care seems to be our focus lately, with the government focusing in particular on non-communicable diseases. This program is indeed an excellent caliber and crosses everything from primary care straight to palliative care and everything in between. So I want to congratulate you. The association between Johns Hopkins and the Medical Association began in late 2010, early 2011, with Professor Morn reaching out to us in the Division of Cardiology, and then it expanded to the endocrinology group, and we are now pleased to help the GI hepatology group. It is our privilege to support all CME initiatives that help bring cutting-edge, research-based, evidence-based information to our physicians that may not be as readily accessible to our country. So thank you. On behalf of the Medical Association, we welcome all of you, and we appreciate you coming to share your knowledge with us.
Thank you, Dr. Chamley. Now it's indeed a pleasure for me to introduce someone, Dr. Maria Bartholomew, who I've known for, we will not date each other, right, for a long time. Dr. Bartholomew is a practicing gastroenterologist in Trinidad and Tobago, and she's truly one that cares about patients. I've known her for years. She's been a strong patient advocate and a leader in the field. So, as I said, not to say too much about us, but I would like to invite you, Maria, to come up and say a few words.
Thank you. Thank you to UTT for inviting me to speak this morning. Thank you, everybody, for waking up and coming. How do I do this? This is the remote? So I was asked just about a week ago to give a little chit-chat this morning on digestive diseases in Trinidad and Tobago. So this is just a little overview with a bit of data that I could put together. And as I mentioned, that Prof. Narayan Singh made the point that we really need to be doing some more work on gathering data and epidemiological information with respect to diseases in our land. And I guess I have to say mea culpa, because I really haven't produced much with respect to epidemiology of GI diseases, but with a little help from a few friends, I managed to put together a few little things. So a few snapshots. How do I? Okay, thanks, great. Okay. So some of you are at Lyman this morning. I might not remember where you are. How do I do the pointer? Anyway, here we are, Trinidad. We only spend 3% of GDP on health. We could do better. So most of us know this, but 34% of the people in this room are of East Indian descent, another 34 African descent. We've got a smattering of Caucasian, Chinese, Syrian, Lebanese, more folks here in Trinidad. And the rest of us are mixed or mixed up. So let's Why isn't it showing the whole slide? Anyway, the top of the slide is a little cut off, but never mind. So I'll just touch on a few disorders and just give you a little idea of what's the state of play here. So, cancers. We're going to hear a little bit later on from Joanna on colorectal cancer screening. And so it's relevant. Trying to find your pointer. Where's your pointer? What's your name? Adam?
Yes.
Okay, Adam.
This
Okay.
one at the
Oh,
top
that's
is
all right.
personal.
Right, got it. Okay, folks, other speakers, pointers on the top of you probably know. So, colorectal. Oh. There we go. So, number 2 in men, number 3 in women. So we look forward to Joanna's recommendations. As with anywhere else in the world, colorectal cancer, the biggest risk factor for cancer is just getting older. But note that we're starting to see the jump in the mid-40s. And this sort of is similar to what you see in the US as well with respect to colorectal cancer in the African American population. And I think we're pretty similar. So if we're talking about a screening program here, I think we should also be thinking about starting earlier than 50. So this is for female cases. This is the latest data I could get, 2003 to 2007, 505 cases during that period. This was interesting, I thought, that again, higher prevalence in the people of African descent as opposed to people of East Indian descent. Now, how we determine ethnicity is another question, but we can come back to that another time. This is a little study done by some medical students of mine way back in 2002. They've grown up to be, most of them have grown up to be specialists now, unfortunately. Most of them are practicing abroad. We need to find ways to get our bright young doctors back. And of the colon cancer cases that they picked up, only 17% were picked up using the old Duke's classification, Duke's A and B. So we're not picking up cases early enough. So let's switch. We're going to hear about fecal transplantation a little later on and learn about its use in the treatment of inflammatory bowel disease. So we do see a fair bit of inflammatory bowel disease. Again, we don't have great data. This is a support group that has been recently established, and they're doing a really good job, and they've got 140 members so far with inflammatory bowel disease. I would say probably averaging, I don't know, Ricardo, I think on average maybe about 500 to 600 cases nationwide when you look at all our clinics and add up the cases. Okay. Charlie Edwards in Barbados did a really nice study, so he's put us to shame. And this was published a couple of years ago. I can't remember the journal. And the IBD prevalence in Barbados was 44 per 100,000 persons. You see 36 to 53 with lower prevalence with Crohn's disease. So this is much less than you'd see in the developed countries. And I think when you do the maths, it's about the same prevalence that we guesstimated that we have. So in Barbados, they'd see approximately 8 new cases a year. Our population is about 4 times that of Barbados. So just for comparison, in the adult population in the US, the prevalence is 200 cases per 100,000. Okay? So we've seen a fair bit of inflammatory bowel disease, but not to the extent. Thank God, because I don't think we'd have the resources anyway. Our case, just to mention that we are managing to treat the bad IBD patients with the biologics, Humira and Remicade, are paid for by the government, and it's free for the patients. So let's flip to the liver. More fun. Deaths from liver disease in 2008. This 2008 is the most recent data from the Central Statistics Office. Number of deaths, 164, so they say. More male than female, and I would guess that alcohol would be the factor there. Oh, that's the next slide. So yes, because here we have it. We're told, if you're to believe the data, that we only had 52 deaths from alcohol liver disease in 2008. Most of them males, huge 43 to 9 male to female ratio. If you look at cirrhosis mortality per 100,000, this is the data for the Caribbean, and we're 11.7, which actually is pretty similar to the US. So Trinidad is this little dot there. Here we are here. Same range as the US. But how good is our data? So I actually went down to the Central Statistics Office. I see some people laughing. You ever went down there? No? So first of all, you have to find it. It took some doing to find it because we're in a temporary office with no sign, somewhere in Frederick Street above a mall. And I eventually found the place, walked in, and as you walked in, this is what greeted you. So I sneaked a picture with my camera, and there were these boxes lying around the place. To be fair to them, I think they're going to move soon, and the new home mightn't look like this. But what might look the same in the new home is this. And this is the cupboard where all the death certificates are stored. And Stacey's shaking her head. You know the story. So there are about 4 years of death certificates in this cupboard that have yet to be analyzed. Can you believe it? And when I went in, the guy whose job it is to analyze and collect this data and sort it out, when I went to his desk, he was playing Sudoku. So you can see why there's a backlog, because it takes time. He's busy. Yeah. And plus the forms are completely outdated. They have to read these carbon copies. They can't read half of what's on it anyway. It doesn't come through because this is the back copy, number 3 copy that they're trying to get the data off, right? And it's so old. These forms are so old that there's actually, I never noticed it before, but there are check boxes for illegitimate and legitimate. Yeah? Right. Stacey. Oh, I didn't notice that bit. I see they learn something new every day. Stacey, we have to do something about this. Okay? So, a long time ago, when I was in primary school, I think, this guy called Courtney Bartholomew got these guys, one named Anthony Kalu and Fulton Defoe, to work on this hepatitis B survey. And as I said, I was in primary school, but I came along and helped them. And so it was quite a big study. We went out all over. It's a know your country kind of thing. We drove all over the country and collected samples, and somehow managed even to get schools to give permission for blood drawing, which I don't think we'd be able to do today. So under 21, there were 2,000 people tested, and same number over 21. So 4,454 people tested, and the hepatitis B surface antigen rate was just 0.7%. You would have thought it would be higher. The antibody positivity, 12%. So basically, the hepatitis B in Trinidad is driven by sexual transmission. We don't have much mother-to-child transmission. So Z will be talking to us a little later about Hep B and Hep C. And we're good at clearing the virus. So very few chronic carriers. I do have some families here with a few families from the Syrian Lebanese community where there's been mother-to-child transmission, and some Chinese community with a mother or father, usually the mother, who's been born in mainland China, or a grandmother who was born in mainland China. What about Hep C? Well, thankfully, very little Hep C. This is the only study that I could find a prevalence rate for hepatitis C. And when I saw the figure, 3.9%, I said, that's pretty high. And the drug companies keep coming to me, you guys have got a lot of hepatitis C, you need to buy our drugs. And I said, but I'm not seeing the hepatitis C patients. So I got in touch with the author of this paper, who's in Switzerland somewhere. I said, where do you get this 3.9% number from? I'm not seeing these cases. And I was told that they got it from the blood bank. This is old data, actually, it's 2002 data from. Right. So I decided to go back to the blood bank and ask them. And I've seen actually referrals from the blood bank, and the majority of them are actually false positives. So I asked them, well, how many Hep C positive patients did you see in 2004? Did you pick Hep C donors? Did you pick up? And 0. Okay. We actually started testing pretty early for hepatitis C in the blood transfusion service, and those patients that in the past 10 years, for example, I've only had about 20 patients referred to my private practice. I can't remember for how many in the public sector. I don't know, Ricardo, how many Hep C patients you have in your clinic at Port of Spain? Yeah, yeah. You're hard pressed to find them. Okay? So why? We will drug abuse. The cocaine is cheap, but we're not injecting ourselves. Okay? Trinidadians are not going to choke themselves with any needle. We're afraid that. Okay? So we have almost zero IV drug abuse. Okay? Hepatocellular carcinoma, again, Z is going to be talking to us. 2003 to 2007, 28% cases. Again, so we don't have much chronic Hep B, not much chronic Hep C, and so the main risk factor would be alcohol. So since I'm no longer in the public, practicing in the public sector, I thought, well, maybe I can dig up some data from my own private practice. And so of 404 liver referrals, what's the actually, non-alcoholic fatty liver disease is the #1 reason for referral. In second place, alcohol, Hep B, and autoimmune liver diseases following. And then at the other end of the spectrum, because we are going to be hearing a little bit about vascular diseases of the liver, some vascular disorders, rare disorders, and pediatric. Oh, any pediatricians here today? I know I'm going over my time, by the way, but I'm taking the liberty. Okay, so we have one pediatric gastroenterologist, just so you know, who's been here back for the past 2-3 years. Where's Sherman? Oh, you're there. Oh, sorry, Sherman. Okay, good morning. So, thank God for Sherman. That's what I could say. No. Because the rest of us adult gastroenterologists have been having to pretend to be pediatric gastroenterologists for many years. Oh, so non-alcoholic fatty liver disease. So Z, you were talking about the long lines in China for KFC. Well, we've got so many KFC outlets here. The lines aren't that long, so you're not going to get the lines that long, but we actually have more KFC outlets per million than you do in the US. So this is a big problem. And Stacy mentioned NCDs, big problem. Look at this. 23, you know this data, Stacy. 23% of our kids who? Oh. Okay. What steps? Oh, right. Okay. Hi, Dr. Kumar. Great. So, yes. So I mentioned too, just a little, I just thought I'd throw this in for you. And these are 2 kids with portal vein thrombosis. So we can do pretty much all the basic stuff with respect to GI diseases. And we're going to learn from you too what we need to bring on next. Certainly, EUS is important. We need to develop our skills with respect to ERCP. But then again, there's some things that we can't. We're just too small, and we still need help from our friends, and we need to occasionally send people abroad for treatment. So these are 2 kids who I got some help from in Miami. So one of the transplant surgeons there operated on them. These 2 kids with portal vein thrombosis. And this is another one of my patients. Again, a little help from our friends. We got TIPS place in the US for her. So I've had a few patients with TIPS place, and they're mostly Budd-Chiari patients. And I'll see a Budd-Chiari case maybe 1 a year or 1 or 2 a year. So that's the boring stuff. This is the important stuff, okay? We need boots on the ground. We have 7 gastroenterologists in Trinidad, which translates to a rate of 0.5 gastroenterologists per 100,000, as opposed to the US, about 4 gastroenterologists per 100,000. Barbados is doing pretty good. Little England, look, same rate as England. See why they call it Little England? Same thing. Okay, so it used to be 9, actually. This month is 9. Next month, Ricardo, it's 7, because we're losing 2 gastroenterologists this month, and by the end of August, 2 Cuban gastroenterologists. So down from 9 to 7. What about in the public sector? Right now, 3 in Port of Spain, Ricardo who's here, and the 2 Cuban doctors. No gastroenterologist at Eric Williams or Mount Hope, no gastroenterologist in San Grande, 1 gastroenterologist, again a Cuban doctor in San Fernando. By the end of August, 1 gastroenterologist in public sector, who's going to be very, he's right there, poor fella. I know what it feels like. 2, we have the help from San Fernando. So 2, but 1 local, 1 Trinidadian gastroenterologist in the public sector. So I found this the other day, gate funding for medical students. This year, this academic year, 250 medical students will enter University of the West Indies, and we will also be funding students in Barbados, Jamaica, and Trinidad. So it'll come up to roughly about 300 students will be funded by the government of Trinidad and Tobago. Right now they're reviewing GATE, and in my opinion this needs to be rationalized. I think we're spending too much money on undergraduate training and zero on postgraduate. So we got to get smart. You're probably not going to be able to read this. But this is a letter that my father received. For those who don't know, my father's a gastroenterologist, and clearly I had no career guidance, that's why I'm here today. And in 1963, he applied to he was doing medicine in Ireland, and in 1963 he applied to the government of Trinidad and Tobago for some funding to help with his postgraduate training. And he got this letter back. I'll just read this paragraph. The Ministry of Health and Housing is of the opinion that it is not absolutely necessary for the ministry to have a person with gastroenterology training, and further adds that such training would in any event not qualify you for a specialist post. I went begging a month ago to get funding for a young doctor for gastroenterology training, and I didn't succeed. So, plus sa chance, plus c'est la même chose. So what are our challenges? We don't have an inadequate healthcare force, in particular not enough gastroenterologists. We lack sophisticated diagnostics in the public sector. We don't have a robust ERCP, where there's no endoscopic ultrasound. Inadequate data. I'll take some of the blame for that one. But Professor Narayan Singh, where's he gone? Oh, you're there. Well, you've inspired us this morning, so we'll have to start thinking about how we can do this and how we can collaborate too. And get help. Cost of treatment is an issue, and well, we're too small for a liver transplant program, but we get help from our friends. So where do we go from here? We need to improve data collection, we need to train more gastroenterologists, we need to become advocates for healthier lifestyles. Stacey, we're going to in particular partner, I think, with our pediatricians, because I think some of our adults are, I shouldn't say this, but we're a bit of a lost cause. Best to start with the kids and get the kids to maybe educate the parents, but we need to increase awareness and care for GI diseases with dedicated liver and GI clinics. I would like to see 2 ideally separate liver and GI clinics. We don't have that yet. And we need to strengthen and develop mutually beneficial partners with our colleagues abroad. But, I'm going to end now. The most important thing that we need is will. Thank you.